Welcome to today's webinar entitled Overview of Liquid Biopsy Testing and Relevance for Invasive Lobular Breast Cancer. My name is Janice Axelrod. I am a founding member of the Lobular Breast Cancer Alliance. I serve as a volunteer research and communications officer for the Lobular Breast Cancer Alliance. I am also a retired gynecological oncologist. On behalf of the Lobular Breast Cancer Alliance, I am so pleased to be moderating for this first session of the four-part series of lobular breast cancer and ILC. Dr. Rebecca Shasky is unable to join us today due to a personal emergency. However, we are very fortunate to have Dr. Julia Foldi with us today to provide an excellent overview on this topic. After Dr. Foldi's presentation, we have time to facilitate a question and answer session. Please feel free to write your questions as it comes to mind in the question box. As they come to you, we will address questions after the presentation. So let me now introduce our speaker, Dr. Julia Foldi, who is a breast cancer medical oncologist at the UPMC Hillman Cancer Center in Magee Women's Hospital and assistant professor of medicine at the University of Pittsburgh. Her research focus is on estrogen receptor positive breast cancer and particularly lobular breast cancers. She's very interested in how we use novel technologies to diagnose and monitor patients with ILC. So now I will turn it over to Dr. Foldi.
Thank you, Janice, for that introduction, and thank you to the LBCA for inviting me to give this introductory talk on liquid biopsies in the context of lobular breast cancer. I'm really delighted to be here, and I look forward to the question and answer session after my talk. So in the next 20 or 25 minutes or so, I will be talking about some definitions. What is a liquid biopsy, focusing on circulating tumor DNA for the most part. But we'll also talk about CTCs, or circulating tumor cells. And then we'll go over some of the unique challenges of lobular breast cancer, particularly the limitations of our abilities to do imaging in this subtype of breast cancer, and why this leads to the particular importance of liquid biopsies in ILC. And then I'll talk a little bit about some of our own efforts at UPMC in how we approach liquid biopsies in different settings, in the metastatic ILC setting, as well as the early stage setting. And in the context of these studies, I'll talk a little bit about some real world scenarios where these assays that we'll be discussing can be used, and how they're currently used. And then, of course, there are some limitations to these assays, and so we'll talk about limitations and future directions towards the end. So to jump right in to some quick definitions, liquid biopsy is a simple blood test that looks for cancer cells or pieces of tumor DNA circulating in the bloodstream. You can think of it like finding breadcrumbs that the cancer leaves behind in the blood. To compare it to traditional tissue biopsies, which is how traditionally we have diagnosed and characterized breast cancer and other cancers, traditional tissue biopsies require a needle or surgery. It can be quite an invasive procedure depending on the site of metastases. It only samples a single location, while we know that cancer, and breast cancer in particular, can affect multiple different organ systems, can be painful and risky, and because of the invasive nature, it's not really feasible to repeat frequently. In contrast, liquid biopsies are simple, based on a minimally invasive blood draw. It theoretically, as to our current thinking, samples all tumor sites, because we assume that wherever the cancer is, it is going to be shedding into the tumor, into the bloodstream. Because it's just a blood draw, it is low risk and minimally painful and can be repeated frequently. So to go into a little bit more detail, there are two types of liquid biopsies that we currently use. One of them is looking at circulating tumor cells. So if you imagine the tumor abutting a blood vessel, those individual tumor cells can move into blood vessels as shown on this diagram here. And those intact whole tumor cells can occasionally be found in the blood. And they can be counted and studied, including looking at markers on their surface. Now, they are more rare in blood than circulating tumor DNA, which we'll move to next. And part of the reason for that is because these cells do not survive long in the blood. When they die, they release small fragments of DNA. And that is what's called circulating tumor DNA, or CtDNA, and this is much more frequently found in blood. Now, they do have a short half-life of about 2 hours in blood, which means that the individual pieces of tumor DNA do not survive very long in blood. They get absorbed and secreted by different mechanisms. And these pieces of tumor DNA can be used to detect specific mutations in the cancer. They can also be used to measure how much cancer is circulating in the blood. So what can we learn from different liquid biopsy tests? There are a lot of newer assays that are being developed for early cancer detection, including some multi-cancer detection tests. These are not within the scope of my talk today, but just so you know that there is a developing field of early cancer detection using blood tests. But what I'll be focusing on are what's labeled number 2 and 3 here. Number 2 being surveillance for micrometastatic disease. So this is in patients who've completed their initial definitive treatment for breast cancer, so whether that's surgery, radiation, and are in remission or on some kind of adjuvant therapy, we can look in the blood to try to identify evidence of disease that is not otherwise apparent, because patients feel well, they don't have symptoms, and there is no cancer that's visible on any imaging. And then number 3 here is showing that liquid biopsies can also be used for treatment selection. And that's in particular in the setting where somebody has metastatic or stage 4 disease. And we are looking for specific mutations in their cancer that we can use to target with specific drugs. And this is also a setting where we can follow how a patient is responding to treatment by monitoring the amount of ctDNA that's present in the blood. So there are 2 types of ctDNA assays. One is what's called tumor-informed, and the other is called tumor-agnostic. And I'll go through these 2 in a little bit more detail. So you might have heard of certain tumor-informed tests. For example, the Signatera test that the company Natera makes. Exact Sciences has a test called OncoDetect, and Guardant also has a test called Reveal. There are also many other tests that are either under development or already available. These are just some examples. In this type of test, there is a requirement for tumor tissue. And so this has to be either from a surgical specimen or from a biopsy. This tumor is sequenced to make a personalized custom panel that's designed on a limited number of genes in each individual patient. We think about this as a barcode. And then once this barcode is available, then it can be used to test the blood sample to see if that barcode is then found in the blood. So the primary use of these tumor-informed assays is in early stage cancers currently to detect the presence of molecular or minimal residual disease after curative intent surgery. The other platform, which is the tumor agnostic platform, examples of this include tests like the Guardant 360 test, Foundation One Liquid, or Caris Assure. This is done using what's called next generation sequencing from the blood only. So this does not require any tissue. It is not personalized, meaning that it's looking for all kinds of DNA that's floating around in the blood. And the next generation sequencing panels look for usually a large number of specific genes that we know are involved in cancer development. This is primarily used in advanced or metastatic solid tumors. And on the right here, I'm showing an example report of what it might look like. This is a Guardant 360 report, which reads out a number of different things, different mutations, and it also gives some examples of what kind of approved therapies we have available based on those specific mutations or alterations, and also gives some information on clinical trials that a patient might be eligible for given those alterations in their tumor. So again, the key difference between these two platforms is one being tumor informed and personalized, which means it's more sensitive, meaning that it can detect smaller amounts of cancer, but there is a requirement for tumor tissue for those tests. The panel-based tumor agnostic tests are more convenient, quicker, but less sensitive, meaning that they require a larger amount of circulating tumor DNA to be able to find it and analyze it. So let's move on to talk a little bit about lobular breast cancer and what's unique about lobular breast cancer. So the more common type of breast cancer is what we call ductal breast cancer, or IDC, also sometimes called NST, which stands for no special type breast cancer. These cancers make up 75% of all breast cancers. They have a protein called E-cadherin that I'm showing here in green that binds cells to each other. It's what's called an adhesion molecule. It is the gene, or the protein E-cadherin is made from the gene that we call CDH1. And because of that, ductal tumors typically form lumps or masses because these tumor cells stick together because of this E-cadherin protein. In contrast, lobular breast cancers, which make up 10 to 15% of all breast cancers, have a defect in the CDH1 gene, which results in the absence of E-cadherin. Because of that, these individual cells are no longer linked together. Rather, they grow in single file pattern. Sorry about that. That's I was hoping to show the histology picture first, but you can kind of see in the background here that there is, instead of lumps, these cells grow in single file patterns. So this leads to a number of unique challenges. One of them being an imaging challenge. So this is just an example of the same patient having two different PET scans. On the left side is a traditional glucose-based PET scan. And there we do not see anything lighting up in this area that's showing the breast and the lymph nodes under the arm. And on the right side is what is a novel PET scan called FES, or estradiol PET, which is imaging the estrogen receptor. And you can see that in that same patient, this is lighting up the lymph nodes under the arm. So we know that there are several imaging tests, including mammography, ultrasound, CT scans, and traditional glucose-based PET scans that have lower sensitivity for ILC. We also know that lobular breast cancers have a unique pattern of metastases. These cancers can spread to the urogenital tract, like the bladder, the ovaries, the uterus, as well as the gastrointestinal tract, like linings of organs, the lining of the stomach or the lining of the gut. And this can delay diagnosis of metastatic disease because it's difficult to detect cancer at those sites. And then another unique challenge in lobular breast cancer is that it is often diagnosed at higher stages, which is directly connected to this issue in imaging. And when we look at long-term survival of patients, comparing ductal breast cancers with lobular breast cancers, we see more late recurrences after 5 or 10 years from diagnosis. And because of that, patients with lobular breast cancers have a worse overall survival compared to patients with ductal breast cancers. So to delve a little bit more into this issue with standard imaging, the core problem is that ILC single file growth pattern leads to it not forming a typical lump that often shows up clearly on a scan. So when a mammogram or ultrasound or CT scan looks at a lobular breast cancer, it might look like normal tissue. So here I'm just showing different imaging tests. On the left side, those that we typically do for the breast itself in patients who have early stage breast cancer. And on the right, whole body scans that we do to look for cancer elsewhere in the body. And showing that the sensitivity or the ability of the test to detect lobular breast cancer is lower than ductal breast cancers. For mammography, for ultrasound, MRIs of the breast are more sensitive for ILC, but these are expensive. They're not used for routine screening and can still miss small lesions. On the right side, we have CT scans, which often miss ILC in the liver, in the GI tract. And I already showed you an example of a glucose-based FDG PET scan, which often does not show ILC tumors because they have low glucose uptake. And then I gave a little bit of an introduction to the estrogen-based PET scan, FES PET, which is better for ER-positive ILC, but not widely available still. So this is just another example of the difference between a glucose-based and the estrogen receptor-based PET scan. The bottom example is the one I showed earlier, just a little bit larger. And on the top, you can see another example of the same patient getting a glucose-based PET scan versus an estrogen receptor-based PET scan with a lesion. This is a mediastinal lymph node that is not shown on the FDG PET, but clearly lights up on the FES PET. And on the bottom example, looking at the lymph nodes under the arm, you can see that there is a group of lymph nodes which shows up on the FES PET, but not on the FDG PET scan. So because of these unique challenges, we think that liquid biopsy may be a uniquely important test in ILC. And I want to talk about 2 studies that I've been involved with using the Signatera assay, which Natera makes, exploring the role of this CtDNA assay during routine clinical use. And this really the idea behind these 2 studies is to get some data on how this test performs specifically in patients with lobular breast cancer and how we can use it for different, to answer different questions. So the first study I'll talk about is in patients with metastatic lobular breast cancer. And we assessed the feasibility of longitudinal CtDNA testing to assess treatment response in patients with metastatic ILC. And then in the second one, I'll talk about another study we did in patients with early stage ILC for minimal residual disease monitoring. So the first study I'll talk about had 66 patients. I'm sorry, that is not the first study. I will first, before I get to the study specifically, I'll just go through this diagram slowly because this is really important. This shows where in a patient's path we can use ctDNA monitoring and where this can be helpful. And here again, we're talking specifically about tumor-informed quantitative ctDNA monitoring that can give us ideas about how the levels are changing over time. So this shows a patient's path from diagnosis of breast cancer to getting local therapy, meaning surgery and radiation in most cases. At that point, a lot of the patients are cured of their disease, but they go on to then be on adjuvant therapy, sometimes for many years. And during that period of time, which can range from 5 to 10 years, or even longer, we can use ctDNA testing to monitor for recurrence. So this is the MRD, or minimal residual disease setting. In patients who develop MRD, or a molecular recurrence in the blood, we hope that we may be able to still cure them with some effective treatment. And we'll talk about this more. But there will be some patients who experience a breast cancer relapse, meaning development of metastatic disease. And we may be able to use our ctDNA test again in this setting to follow how their cancer responds to treatment, develops resistance, grows more. So this is another setting that we can use ctDNA in. And that's what I'll talk about first. So this was two patient examples from a study we did in 66 patients who had metastatic lobular breast cancer. And we used ctDNA monitoring with the Signatera assay to follow their disease course. So to orient you a little bit, the x-axis here is time from diagnosis, and the y-axis is the level of ctDNA found in the blood. The black dots and black line represent the changes in ctDNA level. On the left panel, there is a brown line which represents a tumor marker. And then these red triangles represent CT scans or PET scans, which found disease progression. And then you can see the different treatments on the bottom that patients received. So you can see here that based on the ctDNA level, this patient seemed to have been progressing, which was confirmed with a CT scan. And then the ctDNA level fell again when another therapy was started, but then it started rising again, which showed early sign of progression, was again confirmed with a scan. And then very similar in the right hand side here, this is actually a patient who was able to go from positive to completely negative ctDNA test when they got effective treatment. But after a while, that treatment stopped working, and we could see the increase in ctDNA up to the point where they had a scan that confirmed progression. Treatment was changed, and we could again see a fall of ctDNA to negative. And this stayed negative for a few additional blood tests, and then started rising again, showing that the patient was progressing. So again, what's really interesting here is that we think that we can use ctDNA to monitor for progression, and that the ctDNA test may be able to tell us before a scan shows progression of disease. So I want to now give you a real world example from my practice of what this might look like. So I was seeing a 70-year-old woman who had a stage 2 lobular breast cancer about 9 years before presenting to my clinic. 9 years before, she completed surgery, radiation, and then 8 years of estrogen blocking therapy, which she completed less than a year before I met her. She presented with persistent diarrhea in early 2024, for which her primary care doctor ordered a colonoscopy with biopsies, and that unfortunately showed lobular breast cancer infiltrating into the colon wall. She had a CT scan and a glucose-based FDG PET scan that were completely negative. We did do a baseline Signatera tumor-informed assay, which was positive. Here you can see her first assay came back at 6.6 mean tumor molecules per milliliter of plasma. She started treatment with fulvestrant, one of our estrogen blocking therapies. And you can see how the level of ctDNA decreased. Didn't quite get to 0, but she remained on fulvestrant for 12 months with excellent quality of life and resolution of diarrhea. Most recently, her ctDNA levels slightly increased. So you can see at the end of the line here. And we did get some imaging that now showed new bone metastases, indicating that there was some progression of her cancer. So this is a patient whose cancer was initially not seen on imaging, but we could use the Signatera test to monitor how she was responding to treatment. Another example of from our practice was a patient who had, bone-only metastatic disease that was non-measurable by imaging. Often disease in the bone is very difficult to measure and difficult to follow for treatment response. So this was another case where the Signatera test, which was low positive at diagnosis, was very helpful. And after she started first-line therapy for her metastatic breast cancer, her level actually fell to 0 and has remained 0 for over 6 months. This is also a patient where we did get a Guardant non-tumor informed test. So think back to the initial slides I showed. This is a test that's not personalized. It's just looking for any circulating DNA in the blood. And that test was not able to pick up any of the ctDNA because it's not sensitive enough. She also had tumor markers done at diagnosis that were all normal. So again, not informative in following how she responds to treatment. So again, in this case, the ctDNA was very informative in letting us know that she was doing really well on her treatment. So switching gears slightly, the examples I showed so far were in metastatic lobular breast cancer. Of course, we are very interested in how we can use ctDNA to monitor for recurrences in patients with early stage breast cancer after completing their local therapy. So we again did a study together with Natera that included almost 1,000 patients with ILC and over 6,000 patients with ductal breast cancer, as well as 250 patients who had mixed ductal lobular cancers. These were patients whose physicians sent Signatera testing as part of usual practice. So they were not in a research study, but we were able to look at their de-identified data in aggregate. So you can see here, these are on top, all of the patients we looked at, and on the bottom, the patients who had estrogen receptor positive breast cancer. And both show that in patients with lobular breast cancer compared to those with ductal in blue, there is a higher incidence of turning ctDNA positive during follow-up, up to almost 20% by 10 years, or almost 10 years out. This is in months, so 100 months. Almost 20% of patients had a positive ctDNA test up to that point, which is quite a bit higher than for patients with ductal cancers. So again, indicating that there is something different about ILC, and maybe it's a disease where ctDNA testing has a unique role. When we looked at how patients did they have a relapse or not? So this is looking at relapse-free survival. These are complicated curves, but the bottom line here is that if somebody has ctDNA detected in the blood in this setting, that means that most likely they're going to have a breast cancer relapse. And that was regardless of whether they had a ductal cancer or a lobular cancer. ctDNA negativity is a good prognostic sign, while having ctDNA positive is a bad prognostic sign. And we've seen this in many different studies before. So how might we use this in routine practice? So this is another example that we often see in clinic. A 48-year-old woman diagnosed with stage 3 lobular breast cancer. Her primary tumor was quite large, 6 centimeters. She had a lot of lymph nodes under the arm, 11 lymph nodes. So she received neoadjuvant chemotherapy, surgery, radiation, and started her estrogen blocking treatment, also with ovarian function suppression because she was premenopausal at diagnosis. And she also had targeted therapy with the CDK4/6 inhibitor abemaciclib. This is our maximal possible systemic therapy that we are able to offer today for someone with a stage 3 ER positive breast cancer. She completed her 2 years of abemaciclib and continued on endocrine therapy. She did start Signatera monitoring during abemaciclib therapy. Initially had 3 tests done every 6 months that were negative, but approximately a year after finishing abemaciclib, her Signatera test returned low positive. So at that point, we did body imaging with CT of the chest, abdomen, and pelvis, and a bone scan that showed no evidence of metastatic disease. So this is a scenario that's going to come up more and more often as these tests are being used more. And this is a scenario where we are not 100% sure what to do. So this is an example where we have technology that's ahead of our knowledge. So what do we do? There are several questions in the field that we're not sure about yet. In these situations, we think that perhaps the immune system can clear low-level reactivation of cancer. So it's possible that she could have another test done in 3 months, which might be negative. So in this scenario, we typically would repeat another Signatera at a shorter interval, maybe in 2 to 3 months, and see what the trend shows. Is it higher? Has it gone back to negative? And that can give us some clues about what's going on. Another big question in the field is, can any new therapies rescue this patient from developing stage 4 disease? We don't know, but there are multiple ongoing and already and prior completed trials. And we don't have a clear answer on this just yet, but there are ongoing clinical trials to try to answer this question. Can we give a new therapy to this patient and prevent metastatic disease? And then the third question is how often we can catch blood-only disease before it shows up on scans or causes symptoms. We don't know, but this has to do with how sensitive our blood tests are. So the Signatera assay is one of the first generation assays that is not quite sensitive enough to pick up really small amounts of ctDNA from the blood. Natera has already upgraded their assay to a more sensitive one because there's a lot of competition in this field. There are companies that are making more and more sensitive assays. And so this is a good thing, this competition, because it's forcing the technology to get better really quickly. But if you imagine that you have a very sensitive assay that's picking up a really tiny amount of ctDNA in the blood, then that might give us an opportunity to intervene. While if you have an assay that's not very sensitive, you need a lot of ctDNA to pick it up, then at that point, you might have missed your chance for intervention. So these are some of the unanswered questions in the field. And this is why a lot of medical oncologists, you might have had some experiences with this, are quite hesitant to use these tests in routine practice because we don't have the answers to these important questions. And then last, I'll talk a little bit about a slightly different reason to get a ctDNA test, and this is in the metastatic setting to look for targetable mutations for therapy selection. And this is, for the most part, using those tumor-agnostic ctDNA tests like Guardant or Foundation One or Caris. And I'm showing here a number of different mutations or alterations that have specific approved targeted drugs available. And in breast cancer specifically, these are for breast cancer specifically, PIK3CA, which is a gene that encodes for a protein called PI3 kinase, has several inhibitors. This is also very frequently found in lobular breast cancer. So we did another study which showed that in ILC tumors, so this is now from tissue, about almost 50% of ILC tumors have this PIK3CA mutation, which we can target with specific drugs. When we looked at liquid biopsy, we saw a very similar trend that overall about 40 to 50% of patients have tumors that have this PIK3CA mutation that we can pick up in the blood, and it's higher in lobular tumors than ductal tumors. There are also some other genes that are more often mutated in lobular than ductal tumors, like the HER2 gene or another gene called RB1, and these might have therapeutic significance. So here's another quick example of how we might use this. I was seeing a 65-year-old woman who had de novo metastatic lobular breast cancer with a large primary tumor, axillary lymph nodes, and bone disease. She was on Arimidex, an aromatase inhibitor, because she wasn't really interested in other therapies. She did very well for 2 years with minimal side effects. I was using the Signatera assay to monitor her. When I noticed that her Signatera was rising, her imaging showed new bone lesions and a possible new liver lesion. Because the Signatera assay doesn't give me information about mutations, I also sent a Guardant 360 liquid biopsy test. And this is what it came back. It showed me that she had an ESR1 mutation in her tumor, which means her tumor became resistant to the Arimidex. She also had a PIK3CA mutation, and she had a HER2 ERBB2 mutation. So these were 3 different targets that we could use to pick her next treatment. So this is why we use these tumor agnostic liquid biopsy assays. So again, she had 3 different targets. And just showing here again, these are all the different approved drugs that we can use in these settings. So to quickly wrap up, what I want to leave you with here is that liquid biopsies are a very powerful tool, but currently they have several limitations. One being the sensitivity of the test. You need a certain amount of tumor to be able to detect it. We know that not all tumors shed DNA equally. So if they are shedding their DNA less, you were not going to pick it up in the blood. We know about the tissue requirement for personalized tests, which can be a limiting factor. And I think most importantly, clinical actionability is at this point a question. And these tests are expensive. Insurance coverage is variable, but I think this is getting better. So what's on the horizon? More sensitive tests, new technologies like methylation-based approaches, multi-marker panels. There is a lot of development in artificial intelligence and machine learning to better analyze the results of these tests. We have multiple clinical trials ongoing to try to figure out how to respond to a positive test. And the costs are going to get lower. I think in the next 3 to 5 years, there's going to be a lot more data, and we might be looking at a totally different landscape of how we use liquid biopsies. So my key takeaways, I hope that I was able to show you today the 2 main types of tests, CtDNA and CTCs, or whole cells. I hope that I convinced you that ILC has some unique challenges, and that because of these unique challenges, we may be able to use liquid biopsies in this disease more than in other breast cancers. ILC has some unique patterns that I talked about. Our technology is powerful but has limits in terms of sensitivity, the tumor requirement, and then our actionability. What do we do with the results? And then I'm happy to report that here at UPMC, we have a big research program in ILC. We're very excited about a lot of our studies that are ongoing. And with that, I would like to thank everybody for your attention, and then we can move on to the question and answer session. And I'm going to unshare so that I can better see, but if people want to go back to any slides, I think we can do that if we have to.
I'm sorry. Hi, this is Mason. It looks like Janice might be having some technical difficulties. So I will start with the questions and then if Janice can join again, we will have her join.
Sounds good.
Okay. So we do have a number of questions from the audience. So one question is, where can you see the relative significance of mutation? When is it enough to consider changes in treatment? And are all mutations rated the same as to significance, as in 0.05 is equivalent?
That's a very good question, and it gets into the nuances of how we interpret these test results. So I'm assuming you're asking about the non-tumor informed assays where we can detect mutations, let's say in ESR1 or PIK3CA. So what those numbers you're referring to mean is what we call variant allele frequency, and it basically gives us an idea of among all the DNA that the assay picks up, what fraction contains that specific mutation. And we know that some mutations, for example, ESR1 mutations, don't happen in every single cancer cell. They often start in a single cell, and that cell gains some advantage by having that mutation, and so it starts dividing more. But often, ESR1 mutations are picked up at very low levels. That example you gave, 0.05 or 0.1, we see that very often. We think that that is still significant because if we don't address it, that clone, that cell, or those few cells are going to start growing out more. So for example, for ESR1 mutations, even these very low levels usually prompt us to change treatment because ESR1 mutations indicate resistance to aromatase inhibitors in particular. For other mutations like the PIK3CA mutations, typically they show up as higher levels because those are mutations that are there in the beginning when a breast cancer develops. So typically we see those at higher levels. It does go a little bit into our thinking about treatment, but typically we don't worry so much about the different levels. And if the mutation is there, then we know we have to address it.
Great. Thank you very much. We have a question about, you mentioned there are limitations with FDG scanning. Can you speak, the question from the audience is, oops, I lost it, but why do oncologists order FDG for ILC patients if they do know that it is inferior to FES? So maybe you can talk about when an FES PET scan might be more useful. I know there are differences in why or when they're ordered.
Yeah, so it's a good and important question. I think FES PET is not available widely yet. It's available in large academic centers, but not widely in the community. There is also probably some knowledge gap. Not everybody might be aware of FES PET scans just yet. There are certain lobular cancers which do show up on FDG PET. It's not across the board that they don't all show up. So I think it's important to have a baseline test to know, before starting treatment, if the cancer shows up on an FDG PET, then great, then that's a good way to follow it. But often what we see is that it doesn't, and then it's not a good way to follow it. FES PET is now in the NCCN guidelines, and the way it is written is that it's supposed to be used for initial staging. So that first scan when we're looking for metastatic disease. In ER-positive breast cancers with probably a special role in lobular breast cancers. It has not been tested yet to be used to follow response. So we don't know if we can use it to say, is the treatment working? Is the treatment not working? Is the cancer progressing? Because it's essentially imaging the estrogen receptor. And sometimes our treatments lead to the estrogen receptor disappearing. So for example, for fulvestrant and our newer oral SERDs like elacestrant and imlunestrant, they downregulate the estrogen receptor. And so you cannot use FES PET scan in that setting. So that's some of the limitations. So I think it's becoming more frequently used pending availability, but not quite yet into the complete mainstream.
Okay, thank you. Let's see. Our next question is post-treatment, surgery, chemo, radiation. When is the best time to get a baseline liquid biopsy for a patient with locally advanced ILC? In this case, they're speaking of having ILC in the lymph nodes. Is there a sort of general thoughts you have on this?
So I think that the way the field is going is that eventually we'll be using this sort of instead of imaging. So we need more data, but I think that the most informative is going to be if we have a baseline test, meaning before any treatment, before surgery, before any chemotherapy, any endocrine therapy, just to know exactly where a patient starts. And then get it serially, meaning multiple times at different points during the treatment. We know that in patients who have a CtDNA that's positive before surgery, the surgery alone can convert it to negative. And our different treatments can of course convert it to negative or decrease the level. And that will be a really great, I think it will be a good way to follow treatment response, but we need more sensitive tests and we need more data.
Okay, thank you. Related to this, one of our viewers says, NCCN guidelines don't support CtDNA yet. So what do you think? We need more data. But can you talk about if is there any guidance in clinical guidelines currently? Okay.
Not quite yet. So this gets back to that point about we don't know how to interpret the results. And in clinical oncology.
Okay, I'm struggling.
Hi, Janice, you're back.
Sorry for the technical problems, and I'm sure there was very good questions that I missed. And let me see where we are. If there's,
I'm just in the middle of answering one, so I'll finish this and then we can.
Where should I start from? I don't know which ones you answered.
Janice, Dr. Foldi is in the middle of answering a question, so she'll finish answering that question, and then we'll move on to some other priority questions. I'll ask the next one, and then you can take it from there.
Okay, that's great. Thank you.
So I think, for things to get into the guidelines, you have to be able to show that it somehow improves some kind of outcome. So whether it's improving survival, survival is what most of us care about the most, but at least, improving things like progression-free survival, or in the early stage setting, improving the rate of relapse. And that has never been shown that CtDNA testing improves survival. We have no data to show that. So that's where the big limitation is. It gives us more information, yes, but what do we do with that information to improve outcomes? That's the big question. And until that can be proven that it does improve outcomes, I think it's not going to get into the guidelines, and a lot of people are going to be hesitant to use it.
Thank you. Janice, I'll just ask one more question while you look at them. So related to getting more data, you spoke about some studies you have at UPMC. Are you aware of national trials going on at this time that are enrolling patients related to using CtDNA for monitoring?
Yes, there are. Nothing that's specific to lobular breast cancers,
Hmm.
but there are trials that are specific to estrogen receptor positive breast cancers. Of course, most lobulars are ER positive. So one of them is called the DARE study that's run out of Yale and is specifically in women who have a positive ctDNA assay, a positive Signatera. They are randomized to either continuing the same therapy that they've been on, or they add Ibrance, which is one of our CDK4/6 inhibitors, to their therapy. There's another study called CATE, C-A-T-E, that's coming out of the TBCRC, that's monitoring women who've already completed all of their endocrine therapy. So they might be 7 years, 10 years out from their diagnosis. They're not on any treatment anymore. And in that setting, those patients get a different ctDNA test called Personalis. That's a very sensitive test. And if that turns positive, then they're also given the option to get elacestrant, which is one of our oral SERDs. So those are the two big studies that I know of. There are many others in Europe and others being developed in the US. A little bit of the limitation of the field is that, and this is something that I'm very interested in, is how to make these studies more accessible to patients in a decentralized manner, because, for example, we don't have the DARE study open at our site, so we can't enroll patients on it, even though it should be more simple than how it is designed right now.
Okay. Thank you. Janice, are you ready with the next question?
Yes.
Thank you, Julia. I really appreciate all your discussion and your answer to the questions. In response to the one about the elacestrant study, how do you know how long to give the elacestrant when you make a decision to initiate this?
We don't know. We don't know. That's, again, we don't know. That there is no data on any of this. So I think that in the CATE study, it's for 1 year, if I remember correctly, but that is not based on any kind of evidence. It's basically based on we have to set a time point, and that was what was chosen, and that's what will be done. So we don't know. We don't have those answers.
So there are some additional questions I see in the feed. One is, does it make sense for a patient that doesn't have any signs of reassurance to get a blood test as a base while more data on how to use data on DNA markers is being tested?
So that's the ultimate question, right? I think that everybody thinks about this a little bit differently. I have patients who, when somebody comes to me and asks about ctDNA monitoring in the early stage setting, I am very open with them. I explain these are the available technologies. These are the limitations. We don't know what to do with the results. There are some patients who say, based on that, they are no longer interested. And some patients who say, I understand the limitations. I still want to know. And so that is a very personal choice. I think that, for some people, more information is empowering. For some people, it's anxiety provoking. And so that's something we have to better understand. And there are actually some studies going on looking at sort of psychological effects of ctDNA testing. But that, I feel, is a very personal decision that each patient has to make with their oncologists. And I know that there is some questions that I'm seeing on here about, how to convince your oncologist, or why are so many oncologists not recommending doing ctDNA testing. And that's because of these limitations that I discussed. And I think, even some of my colleagues here at UPMC are very hesitant, and they say, I'm not going to order a test that I don't know how to interpret. Meaning, if it comes back positive, they don't know what to do about it. And that makes a lot of us very nervous, because we're used to having guidelines. We're used to knowing exactly what to do, what are our action steps. And so that makes people very, very nervous. I think that, depending on each patient's relationship with their oncologist, this is a conversation that you can have with your providers. Point out the data, point out that yes, you understand the limitations, but you're still interested in having that information.
And follow up with that question, I have a question of my own about if a patient, I know that you're very active in creating new novel therapies, and this is wonderful that patients say that when they have metastatic disease, they know there's another treatment or drug if they fail the current one. But if a patient has treatment for early asymptomatic disease that's only detected by CtDNA, are you wasting this drug early and they get a resistance, and then when they really need it to make the quality of their life, improve the quality of life, and will it not be there for them?
That's an excellent question, Janice. And that's, again, goes into this question of, do we actually improve long-term survival by doing this testing? Because as you say, if we do a test in someone who feels well, is completely asymptomatic, and then we give them a drug that we don't know is going to improve their outcomes, what that's going to do is give them potential side effects, have an impact on quality of life, and we don't know if it's going to improve their survival. And so this is, again, this goes back to, what do we do with a positive result? Do we give our effective treatments earlier, or do we wait until there are symptoms and we really need the drug? I think the ultimate question is, can we still prevent metastatic disease by giving a drug early, meaning that we wouldn't be wasting our opportunity, but we can actually get ahead of the disease?
The next question I have is one that I also am struggling with, is that if you think that a patient has a positive liquid biopsy and that indicates disease that would not be curable because it is metastatic, although not visible. If you think of it this way, that we have CAT scans and MRIs today that 30 years ago we did not have, and we may not have seen the disease and we would have considered they don't have metastatic disease. Now they have disease that's not seen on imaging, but is seen on liquid biopsy. So these patients who have metastatic disease, known metastatic disease, and now the disease is no longer clinically visible, is no longer seen on imaging, and now is only known because they are told they have metastatic disease based on their history, that they are not curable. And yet they are on years and years of treatment with no evidence of disease. Would a liquid biopsy ever change your mind about designating somebody is not curable, or at least no longer need to remain on persistent treatment for the remainder of their life?
Yeah, I think this is another place where we might be able to use liquid biopsies. So there are some people who are essentially cured from stage 4 disease. It's very rare and not so common in ER positive breast cancer, but in some other types of breast cancer, we do see this. And a ctDNA testing may be able to help us figure out who could stop treatment. We're very hesitant in oncology to use cure in the stage 4 setting, to use that word, but we do see people for a very, very long time living with metastatic breast cancer who we think are actually cured, and this could be another place for ctDNA testing to give us better answers.
Thank you. Another question we have is
we're at 1:00. I don't know if we have to stop exactly at 1.
Yes, I'm sorry. we should probably wrap it up now. We really appreciate the time that you've shared with us today, Dr. Foldi and Janice. And we will try to look through the questions and work through some question answer after this time.
Yeah, I'd be happy to follow up in some way in writing. I see that there are a lot of other questions, so I'd be happy to answer those.
All right. Well, thank you very much for your time today, and we'll sign off.
My pleasure.
Bye-bye.
Bye. Bye, Janice.
Bye.